Yep. All right, so I'm going to be talking about the management of heart failure, and I added the 2017 update to it. They added the guidelines. So just kind of in a generalized, term of heart failure is just a chronic progressive condition in which the cardiac output is insufficient to meet the body's demands. But more specifically, some precipitating causes of heart failure. So there's a lot of things that can cause heart failure. So it's very important whenever somebody is, a newly diagnosed heart failure patient to identify where it came from. So some of these are infection, anemia, pulmonary edema, pregnancy, arrhythmias, thyroid toxicosis, rheumatic heart disease, infective endocarditis, obesity, environmental factors, stress, alcohol abuse, drug abuse, cardiotoxic medications, hypertension, MIs, or congenital heart disease. And those are just some. So, moving on to left-sided heart failure. So, this is kind of broken down into systolic and diastolic. So, when you're looking at the guidelines, you'll see that they use the terms HFrEF and HFpEF a lot. So HFrEF is heart failure with reduced ejection fraction. So this is your systolic heart failure. It is caused by weakening of the left ventricle, also known as a cardiomyopathy. Cardiomyopathies can either be ischemic, so caused by ACS, MI, or non-ischemic. So that's kind of where it's just a broad as to what could have caused that weakening of the left ventricle. So what happens here in systolic heart failure is the weakened ventricle causes a decrease in the cardiac output, which leads to hypoperfusion of the organs. Hypoperfusion of the kidneys provoke the renin-angiotensin-aldosterone system, and this will raise the blood volume and peripheral resistance, which increases the workload of the weakened heart pump. As the ventricle endures a greater workload, further systolic dysfunction occurs, and this will increase the blood volume and lead to hypervolemia. Now, moving on to diastolic heart failure, so this is HFpEF, so heart failure with preserved ejection fraction. This is when the left ventricle loses the ability to relax normally, so there's abnormal filling, distensibility, or relaxation of the ventricles. This causes elevated filling pressures in the left and or right ventricle, which causes a buildup of hydrostatic pressure into the left atrium. This will result in a fluid backing up into the pulmonary venous system and causes fluid to leak in the pulmonary interstitium. Symptoms you might see with left-sided heart failure is your dyspnea, cough, paroxysmal nocturnal dyspnea, so they're waking up suddenly at night and feel like they can't breathe. Orthopnea, or crackles or rales heard on auscultation. If there's any questions at any point, just let me know. Just stop me, because heart failure is pretty complex. Just understanding it and then the management of it is very complex. So if there's any questions along the way, just stop me. So I'm going to move on to right-sided heart failure. So this most commonly occurs as a result of left ventricular failure. So it's just the failure of forward cardiac output. More specifically, it'll lead to vascular congestion in the pulmonary arterial bed with increased capillary wedge pressure, which eventually is transmitted to the right ventricle, and thus compromising its function as it attempts to pump against the increased resistance. When the right side fails, blood and fluid back up into the body's venous system. So some clinical manifestations of this you'll see is the jugular vein distension, peritoneal edema or ascites, or the peripheral edema. Isolated right heart failure, so this is commonly caused by pulmonary disease. Another term for it is cor pulmonale. If you ever see in documentation a patient mentioning biventricular heart failure, this is so when there's speaking of this, it's a combination of left-sided clinical manifestations and right-sided clinical manifestations of heart failure. So I kind of wanted to talk a little bit about the HFrEF and HFpEF because I'm going to be using that a lot in this presentation. So HFrEF is heart failure with reduced ejection fraction. So this is ejection fraction that's less than 40%. Heart failure with preserved ejection fraction is one ejection fraction that is greater than 50%. There's two other terms that are rarely ever used, and I don't think I've ever used them in documentation, but it's just good to know. So HFpEF borderline is an EF that is 41 to 49%, so it's just kind of in that middle range. And HFpEF improved is somebody who had a reduced ejection fraction, and now it's improved greater than 40%.
We should try to use that today, somehow.
Somehow
look at it.
Yeah. Let's see. So in my documentation, I always will make a note of what kind of heart failure they have. Is this, if they have a cardiomyopathy, is it ischemic? Is it non-ischemic? If it's diastolic heart failure, what are the comorbidities that are contributing to the diastolic heart failure? So I try to add all those into the document, as well as what is their ACC stage of heart failure? What is their NYHA class? What is their EF? And do they have an ICD or CRT? And what's their volume status? All those things are going to be important, not only just for anybody that's looking at the document, but that if you're trying to get some medications that are not easily approved, like your Entresto or Corlinor, all of that is going to be important to have in your note. Okay, moving on to the ACC stages of heart failure. So stage A, these are the patients that are at a high risk for heart failure but currently have no structural heart disease or symptoms. So for example, these are going to be your patients that have hypertension, atherosclerotic disease, diabetes, obesity, or a metabolic syndrome. Or also patients that use cardiotoxic medications or maybe have a family history of cardiomyopathy. Stage B, so these are patients that have the structural heart disease, but they currently don't have any signs or symptoms of heart failure. So these are your patients that have had a previous MI. They have some LV remodeling, including LVH, so left ventricular hypertrophy, and or in low EF or asymptomatic valvular disease. Stage C, so these are the patients that have the structural heart disease and they have had prior symptoms of heart failure or current symptoms of heart failure. So any patient that has had heart failure and they've had symptoms, at any point going forward, they're going to be ACC stage C. So stage D, of course, is your refractory heart failure. So this is your end-stage heart failure. So patients have symptoms of heart failure at rest, and they have recurrent hospitalizations despite guideline-directed medical therapy.
Can I ask a question?
Yeah.
First of all, I'm always glad when she's seen the patient before me, because then she's got all that in there, and I don't have to think about it or and try and look at my notes. So it's always awesome. But did you say, because I didn't, if they have ever had heart failure symptoms, they'll never. So they're now a stage C.
They're
so they
stage
can never be a B
again.
again.
They'll never be B.
Gotcha.
So no reverse staging in ACC.
Gotcha.
No.
Okay.
Because they've had changes, scar tissue in the
They've
heart.
had the changes and then they've had the symptoms.
Okay.
So if they have the structural changes, but they've never had symptoms, they're going to be stage B. But if they've had the structural heart disease with prior or current symptoms of heart failure, then
So once you
they're going
cross
to
the
be
line, you never
yeah.
go back.
Interesting. So now I want to move on to the New York Heart Association Functional Classification of Heart Failure. So again, this is something I always put in my note. It's good because anybody that reads this note will be able to kind of see what their functional status is. So a class 1, this is where they have no limitation of physical activity. Ordinary activity does not cause fatigue, it doesn't cause palpitations or dyspnea. Class 2, so this is a slight limitation of physical activity. They're comfortable at rest, but running errands or spending a little bit too much time on their feet, this is going to cause pretty much profound dyspnea, fatigue.
So are we just talking like with ADLs, like just daily?
Yeah, well, it's not just with ADLs, it's more like just prolonged physical activity.
Okay.
Your NYHA class 3 is more your ADLs, which is broken down into 3A and 3B. You don't necessarily have to use 3A or 3B, just know that the difference between 2 and 3 is 3 is more, you're having these symptoms, these patients are having symptoms with ADLs. So just ordinary minimal physical activity is going to be causing palpitations, dyspnea, or fatigue.
So maybe like,
But they're comfortable at rest.
so maybe like dusting does not cause symptoms, but vacuuming does. That would be like the A, and then dusting, like just doing minimal things causes.
Right.
Okay.
Yeah. Those, like I said, unless you really know the difference between the 3A, 3B, you don't necessarily need to use them in a document. You could just use 3.
I don't think it's mattered with the Entresto if we've ever really deciphered between the A and B portion.
No, it doesn't. I always use it just because I like to.
Because you know it.
What about in the Pinnacle? Doesn't that prompt you
It
to
does ask.
It does
A
ask
or B,
3.
so-
Yeah, 3A or 3B.
I think vacuuming is a really good indicator of their physical ability, because vacuuming
It
is
really
hard
is.
for
It is
people.
harder for-
Yeah, it is.
So that's
Makes me
why.
winded.
Huh?
It makes me winded.
Like, say a patient tells me, I have trouble walking from my kitchen to my living room. That's 3B. That's 3B. But stage 4 is easy. So this is patients cannot carry on any physical activity without having discomfort, and they have the heart failure symptoms at rest. So this is kind of more your end stage. But the thing with NYHA class is that they can, change from time to time. So even though they might be a class 4 one time you see them, they could possibly improve to like a 3 or maybe a 2.
So this one you can go back.
This one, yeah. This is just
Never in
purely based
ACC.
on symptoms.
Just
Yeah.
the symptoms can improve, but your structure of the heart change won't.
Right.
Megan, do you talk about defibrillators?
Yes.
Okay, because I know I ran into where there's certain stages that they will only cover, if they won't cover for 4.
Yeah. And I'm gonna I'll go
Okay.
over all that. So now we'll kind of get into the guidelines. So ACC stage C, so remember these are your patients that are at risk for heart failure. They have the some comorbidities that put them at risk. This is kind of where you would want them to talk about, leading a heart-healthy lifestyle, trying to prevent vascular coronary artery disease, and prevent left ventricular structural abnormalities. So you want to make sure that you have their hypertension under good control. You could start an ACE inhibitor or an ARB in patients that have the vascular disease or even diabetes. And any patients that have lipid disorders, statins would be the recommendation for that. Any conditions that contribute to heart failure, such as diabetes, tobacco use, cardiotoxic agents, obesity. So these should all be controlled or avoided if possible. Okay. So moving on to stage B, so these are your patients that have structural heart disease, but no symptoms of heart failure. So you want to prevent heart failure symptoms or further cardiac remodeling from happening. So in all patients that have had a recent or remote history of MI or acute coronary syndrome and also have a reduced ejection fraction, you would want to initiate an ACE inhibitor or an ARB at that time. Any patients that are intolerant to ACE inhibitors, that's kind of when you would consider an ARB, if appropriate. So, in addition, all patients that have had the recent or history of MI or acute coronary syndrome and also have that reduced ejection fraction, they should be started on evidence-based beta blockers. And these will be used to help, to reduce mortality.
And there are certain beta blockers, right?
Yeah, I'm going to go over that.
Okay, great.
Yeah. So these patients should also be on statin therapy to prevent symptomatic heart failure and cardiovascular events. But really, going back to the beta blockers, they should be used in all patients that have a reduced EF. Whether or not they had an MI or acute coronary syndrome, if they have a reduced EF, a beta blocker should be on board.
What percentage do you?
Reduced EF, so this would be a patient that has a less ejection fraction.
Less than 40? Okay.
Yeah. So I'm not going to go in great detail on this slide about the ICDs because I have some slides later on about that. But in selected patients, if their LVEF is less than 35%, that's kind of when you would want to think about an ICD. But like I said, I'm going to go into more detail about when you should be thinking about that. Also, in selected patients, any revascularization or valvular surgery would be indicated. I did want to add this in here. So the non-dihydropyridine calcium channel blockers that have the negative inotropic effects, they can be harmful in patients with a low EF. So like your diltiazem and your verapamil, if you notice that your patient has an EF less than 40% and they're on either one of these medications, at this point you would want to switch them. So either discontinue, maybe start digoxin if it's if they're already on a beta blocker and you have the diltiazem for added, to reduce the heart rate, you could either consider digoxin or maybe if they don't have AFib, you could consider Corleone. But I'll get into all that too. Like I said, it can be kind of confusing, so stop me at any time.
With stopping the DIL or the verapamil, could you just increase the beta blocker if it's not an AFib patient?
Yeah,
and the pressure can withstand it.
If it's not at maximum dose, you could.
Even if it is an AFib patient, you can still use the beta blocker.
I'm just saying, instead of putting on DIG.
Oh.
Yeah, if they're not a maximally tolerated dose of beta blocker, you would definitely want to do that first.
Okay.
So those are some treatment options for stage B, but now we're going to get into stage C. So this is pretty comprehensive. There's so much with patients with a reduced ejection fraction. So the next several slides are going to be about ACC stage C HFrEF. So with the NYHA class 1 to 4, our goals of therapy are just to control their heart failure symptoms. We want to improve their quality of life, prevent hospitalizations, prevent mortality, and provide education. So GDMT is our guideline-directed medical therapy. Some drugs are routinely used for patients that have the NYHA class. I put class 1, but it can be class 1 to 4. So this would be your ACE inhibitors or ARBs. So the beta blockers. So these have been shown to reduce all-cause mortality and decrease hospitalizations in patients that have reduced ejection fractions. But if you have any patients that have a reduced ejection fraction and you see that they're on either atenolol or metoprolol tartrate, at that point you would want to stop those and start the evidence-based beta blockers, which are carvedilol, metoprolol succinate, or bisoprolol.
So what's better about the metoprolol succinate versus the tartrate?
Well, just in the studies have shown that they have a better outcomes with those than they did with the atenolol or the metoprolol tartrate. So drugs that are routinely used for the NYHA class 2 to 4, and these patients that have a creatinine clearance greater than 30, or they have a potassium that's less than 5. You would still want them to be on an ACE inhibitor or an ARB, a beta blocker, diuretics is needed. At this point, this is kind of where if they're class 2 to 4, you want to start thinking about putting them on an aldosterone antagonist, so spironolactone or eplerenone. This is a class 1 recommendation for HFrEF. I will note that, I did put creatinine clearance greater than 30, potassium less than 5, but also you want to look at the creatinine too. So if the creatinine is less than 2 in women or less than 2.5 in men, you can think about initiating the spironolactone or eplerenone. I will say that I always start with spironolactone, and if they can't tolerate that, then I would try eplerenone. If they're having like the breast tenderness with the spironolactone, you can try eplerenone. I will say though, after starting the aldosterone antagonist, you have to routinely monitor renal function and potassium.
How often do you monitor them?
The guidelines say, like, after you started, you need to, obtain a BMP in a week, and then I think it's like 3 weeks, and then a month, and then 3 months thereafter.
Is that with anybody who gets put on those? Mm-hmm. So I know, like, a lot of times we'll do it like anywhere from 10 to 14 days. Well, I'd say 7 to 14 days, depending on the patient and their labs, and then we don't really check them much after that. Like,
and that's
hopefully
you don't see
someone
that
is.
a lot.
Yeah, hopefully someone is.
I would say,
Primary might be.
I think,
if they've been
and if they've been on them for quite some time, tolerating them just fine, you could probably space out the amount of times that you're checking. But I definitely, at least every 6 months to a year, I would be checking.
well, and I know we do. That is something we do. But we don't do the 1 week to 3 week, and then on our typical patients. So I just didn't know.
Yeah, so that's
okay.
That's what the guidelines say.
When you first started, it's kind of scary.
Yeah, we always check after first starting.
Yeah.
So, on the inpatient side of things, since I'm still seeing inpatients too, I've had a couple of times already where I felt a little uneasy about initiating spironolactone because, whether they're in the hospital for new kidney issues or underlying, it's difficult to say when their creatinine's reaching a good baseline and it's not going to pop back up. So
I'd say unless their renal function is completely stable in the hospital, it hasn't really.
So if
they haven't had much issues, then you could think about starting.
But if there have been any issues, probably.
If there have been any issues, I would just hold off and wait for that to be done in an outpatient setting.
Okay.
When things have kind of stabilized. Okay. Still talking about stage C, HFrEF. Some drugs that are routinely used for NYHA class 2 to 4. So any patient that has adequate blood pressure control on an ACE inhibitor or an ARB, and they're already on guideline-directed medical therapy. You would want to start thinking about discontinuing the ACE inhibitor or ARB and starting Entresto. Of course, if they're on an ACE inhibitor, you would have to have a 36-hour washout period before you could start Entresto, because ACE inhibitors and Entresto interact with one another. So if I was going to start Entresto, I decided to discontinue the ACE inhibitor on a Monday. They wouldn't start their Entresto till Wednesday.
So they're still recommending that we start them on an ACE inhibitor or an ARB first, and then switch them to Entresto. Mm-hmm. And
there's some cases though that, and they don't really do it in the hospital. It's mostly outpatient. So in the hospital, they are already starting them on an ACE inhibitor or an ARB. So when I see them outpatient, if they're tolerating it okay, at that point, that's when I want to switch them.
And technically you put on here class 2 to 4, so they have to be having some kind of symptoms.
They have to be having symptoms. You're not going to get Entresto approved unless they're having heart failure symptoms. So that's why it's always important to put in your note where their functional capacity is.
Okay.
This is a class 1 recommendation, and so the goal with Entresto is to reach the maximally tolerated dose. So, I usually will start them on the low dose, the 24, 26 milligrams twice a day. And then I usually will see them back in at least a couple weeks, have them get some blood work, see how they're doing on it. I did put in here that you may want to consider decreasing or discontinuing a loop diuretic if appropriate, because Entresto has two components to it. It has the valsartan and the sacubitril. So the sacubitril actually increases the natriuretic peptides in the body, so you're going to get natriuresis and diuresis with Entresto. So you might not need as much of a loop diuretic. It's solely based on how they're presenting to you. So if they still have quite a bit of fluid on them, I'm probably not going to touch the loop diuretic. But if they're pretty euvolemic, I might consider either dropping that loop diuretic way down or even discontinuing it altogether if they're on just a small dose of it. So it just kind of depends on the patient.
My goodness, if you came over to our clinic and saw our patients, you would probably change all their drugs.
She's like, yeah, I probably.
You could refer them to the heart failure.
Well,
What is your clinic? Is that the wound clinic?
yeah, it's the wound clinic. I mean, everybody that comes in, I've got edema up to thighs, I've got it in the abdomen.
So what are they on? Generally speaking.
Generally just usually some are on hydrochlorothiazide, some are on, torsemide, some are on Lasix, but it's just not aggressive. It's not
Are they
aggressive.
on-
It's not
Are they on
aggressive.
some of the other guideline-driven therapies?
I tell you, my focus isn't on necessarily all of that aspect of it because I'm focusing on the leg, but I'm thinking I need a whole lot more med management.
Yeah, because that sounds like it's kind of
What
more
a
like
project for my
anesthesia,
student.
or
Maybe,
having general
do you have
anesthesia.
everyday clinic?
We have people in there every day. I mean, it's. So, we have other doctors seeing these patients
Right.
as well. So, I think we can wrap them till the cows come home, but if we're not addressing some of these other
Right.
issues,
Right.
Maybe we could see patients in her clinic once in a while. I don't know how that all works.
It'd have to
but-
be, like self-referred.
Yeah.
we gotta think about this.
Yeah,
That's a good point. That's a
Yeah.
really good point.
it is. So, just a side note that Entresto is contraindicated in patients that have had the history of angioedema. So, if they've had that, you don't want to start Entresto. Ideally, what your guideline-directed medical therapy would be in this case would be you'd already have them on a beta blocker, or they'd already be on an aldosterone antagonist, and then of course you would be starting your Entresto. I will say that that's not always the case. Sometimes, just the aldosterone antagonist, yeah, we want it, but sometimes just the patient can't tolerate it due to renal function. So they might only be on Entresto or a beta blocker, and then the loop diuretic is needed. So I thought this was important to add too, because the hydralazine isosorbide dinitrate, whenever I first started in heart failure, so this would be used from time to time, and I could never wrap my brain kind of around, why. It was always difficult for me to figure out when I should be initiating these drugs. So to kind of break it down, any of your black patients that are already on guideline-directed medical therapy, so they're on the beta blocker, they're on an ACE inhibitor, or an ARB, or Entresto, and maybe on an aldosterone antagonist, but blood pressure's still not under good control, you want to think about adding the hydralazine isosorbide dinitrate. This is a class 1 recommendation. And then on the other end of things, if you have patients that cannot take an ACE inhibitor, ARB, ARNI, so that's your Entresto, or aldosterone antagonist due to renal function, hypotension, or drug intolerance, that's when you could think about adding the combination of hydralazine isosorbide dinitrate. That's a class 2A recommendation. And this is with HFrEF too. So, just to be clear, that, it's with HFrEF, but you could also think about doing it with HFpEF.
Any patients, not just blacks, you can do that at that time.
Do you start one and then the other, you start them both at the same time?
Same
and
time.
see how it goes? Okay.
Yeah.
What dose do you start at?
It just kind of depends on the patient, but
Blood pressure.
blood pressure and all that. Usually, if blood pressure is kind of borderline, I'll just start them down, both on low doses, the lowest doses of each.
Is it a combination med or you just start them at the
It
same
can be a combination med, but I would advise not to do that. I don't think it's as covered as well
time? Oh, okay.
if you do the combo.
Gotcha.
So if you just prescribe them separately, then
You know, they're all like, oh, more pills.
I know. Yeah.
Well, do you want to die?
Right. But you're too tired, like, that's one of those things.
All right, so still talking about CHC, still talking about HFrEF. Our patients that have the NYJ class 2 to 4, so they're having the symptoms. If they have a heart rate that's greater than 70 beats per minute, they're on maximum dose beta blocker and have no history of AFib. This is when you could think about starting Corleone, ivabradine. It's a class 2A recommendation. We do have quite a few patients that are on Corleone. I will say that it's one that's very hard to get approved, especially if a patient has Medicaid. So making sure that you have all those key elements in your documentation is going to be important for getting this one approved. And you have to be able to show too that they have no history of AFib. So if you're thinking about starting Corleone, you probably should get an EKG and make sure that they're in sinus tach or sinus rhythm with a heart rate that's greater than 70. And I say maximally tolerated doses of beta blockers. So we do have patients that can only tolerate, say they're on metoprolol-succinate, they can only tolerate 25 milligrams because their beta blocker just makes them so tired. So even though they're not on a maximum dose of it, that's all that they can tolerate. So that's when you can initiate the Corleone.
Does Corleone affect their blood pressure as well? Or is it just their heart rate?
Heart rate.
So like if they're on a maximum tolerated dose because of blood pressure of their beta blocker, you could consider adding Corleone even if they have like borderline blood pressure.
Yeah.
Okay.
Yeah, absolutely.
Because that would probably be the more common thing that I see.
The risk though with Corleone is that it has been shown to cause AFib, so just kind of keep that in mind. But this is, I initiate Corleone when I have patients that are still having just ongoing heart failure symptoms and the heart rate is just still not well controlled, then I will start Corleone. But like I said, we have quite a few patients on it, but I wouldn't say an abundance of patients on Corleone.
Do you look at their echo too to see if like their atria are enlarged? Because isn't that kind of doesn't that increase your risk for AFib?
It does, but
do you like consider that or just look at strictly EKGs and
yeah.
okay.
Any other questions, Corleone? All right, now I want to talk about our ICDs. So, patients that have HFrEF, stage C, they're having class 2 to 3 symptoms. So this means they're not class 1, they're not class 4, just class 2 or 3. They have an LVEF of less than or equal to 35%. They have greater than 1 year survival. They're greater than 40 days post-acute MI or greater than 90 days post-PCI or CABG already on guideline-directed medical therapy. So, once a patient has an MI or, and they've had a PCI or CABG, at that point you could get them on guideline-directed medical therapy and then you would recheck an echo after this certain amount of time. So, if they're just 40 days post-MI, you would check an echo after 40 days if they've been on guideline-directed medical therapy. But if they've had an intervention like a PCI or CABG, then you could wait 90 days on guideline-directed medical therapy. At that point, if that repeat echo shows that the EF is less than or equal to 35%, that's when you would refer for an ICD. But they have to be class 2 to 3 symptoms. So this one's a little different. So this is class 2 to 4 symptoms. Still have HFrEF, still stage C. So they have an LVEF of less than or equal to 35%. They have normal sinus rhythm, but their QRS is greater than 150, greater than or equal to 150 milliseconds, or they have a left bundle branch block pattern, and they're already on guideline-directed medical therapy, then you could think about referring them for ICD.
I don't know if they would approve this for class 4.
Really?
That's what Dr. Miller said.
This is specifically for people who, really the only change is like the QRS
Yeah, so this is...
and the left bundle, right?
Yeah.
Okay.
Yeah. The previous slides, this is our patients that have had those, post-MI, post-intervention, and we're rechecking the echo, and their EF is still not improved on guideline-directed medical therapy. But this is a little different because this is just going off of the QRS and that left bundle branch pattern. So if they have one of those, then either of those, then that's when you would want to refer to an ICD, and they can be class 2 to 4 symptoms. I did want to talk about CRT, so your continuous resynchronization therapy. This is a little confusing, this slide. I couldn't really make it not confusing. I don't know how to simplify it. So I'll just try to explain it to the best of my ability. So patients that have a cardiomyopathy, they're on guideline-directed medical therapy for greater than 3 months, or they're on the guideline-directed medical therapy for greater than 4 days post-MI. Patients that have had already the implantation of the defibrillator, in their EF is less than or equal to 35%. So if they're anticipated to require ventricular pacing greater than 40% of the time, this is when you would want to think about a CRT. So if they're being paced in that right ventricle greater than 40% of the time, and I'm going to talk about that too, that's when you would want to think about CRT, because you could get the pacemaker-induced cardiomyopathy. So also in AFib, if ventricular pacing is required, and the rate control will result in nearly 100% of ventricular pacing with CRT, then that would be an indication for that too. I will say that patients that do get the CRTs, they do much better afterwards, because there's not that dysynchrony of, the being paced from the right ventricle, and it causes dysynchrony with the left and the right. So once they have the CRT, it's now synchronous, and they do a lot better after that. They also have to have the class 2 to 3 symptoms, some other things to look out for. Obviously the low EF, a QRS greater than or equal to 150, that left bundle branch pattern, or sinus rhythm. So I wanted to this really isn't in the guidelines, but I wanted to touch on it a little bit more because we will see this from time to time. It's really important to look at your device reports, and the patients that have a device, you want to go back and look at their device reports and look and see how much they're being paced in the right ventricle. So if they have a single or dual chambered pacemaker, this can cause ventricular dysynchrony. If they've had a fall in EF of greater than 10% after the pacemaker is placed, that's usually an indicator of the pacemaker-induced cardiomyopathy. But of course you would want to exclude other things first. You would want to exclude, are they having ischemia? Is it maybe a valvular disease? Are they having atrial arrhythmias? Are they being paced greater than 20% of the time in the right ventricle? So if I'm looking at a device report and I see the RVP, the percentage that they're being paced in the RVP is greater than 20%, then it's kind of a red flag for me, and then they're having all these heart failure symptoms. That's when I usually will refer to EP for consideration of CRT, and let them kind of take it over from there. Moving on to HFpEF finally. So this is our diastolic heart failure. class 1 to 4 goals of therapy: control symptoms, improve quality of life, prevent hospitalizations, prevent mortality. It's funny because the guidelines don't provide education in there, but that's also equally important in your HEP series, if not more. And you also must identify the comorbidities, because like I mentioned earlier, your comorbidities are going to be huge in keeping that diastolic heart failure under control. I would say HFpEF is way more frustrating than HFrEF for me. Our diastolic patients can be difficult. There's not a whole lot of treatment. It's just obviously treating the comorbidities is going to be the huge thing. So if they have hypertension, you want to get the blood pressure under good control. If they have AFib, make sure, or even sinus tach, whatever, make sure that heart rate's under good control. If they have coronary artery disease, make sure they're on guideline management for that. Diabetes. If they have sleep apnea, we want to make sure that we identify that and treat it. And also weight loss is going to be very important, as well as diet. So one thing that they did add to the 2017 update is they added aldosterone antagonists as a recommendation for HFpEF. So this is a class 2A recommendation, and it's the same guidelines. Make sure that their GFR has to be greater than 30. Their creatinine must be less than 2 in females, less than 2.5 in males, and their potassium has to be less than 5. So same guidelines there. But in appropriately selected patients, these can be very helpful. I kind of wanted to touch on the comorbidities in heart failure. There is some recommendations of those. So your anemic patients, this is a class 2B recommendation. So if they have NYHA class 2 to 3 symptoms and they have iron deficiency, intravenous iron replacement is recommended. But on the other end of things, if they have heart failure and anemia, the erythropoietin stimulating agents should not be used because there's no benefit. So.
Do you do outpatient IV iron replacement, or is it?
So a hematologist would be the one to manage that, but
Would you refer them to heme, or would you send it to the primary to do?
you could refer. Yeah.
Excuse me.
Just some things you would look out for with the iron deficiency anemia is the ferritin levels. So if it's less than 100 or 100 to 300, and their transferrin saturation is less than 20%, that's when the IV iron replacement is reasonable.
So are you monitoring their iron levels and things? Or if you
typically
suspect,
don't.
you just...
If we suspect, if they have ongoing anemia, then we can kind of do more exploring.
Okay.
I will say though that select few patients that have had the IV iron replacement have done really well. I mean, it's really remarkably improved their heart failure symptoms. So, hypertension is huge in heart failure. So basically in HFrEF, HFpEF, we need to have that blood pressure less than 130/80. I will say that HFpEF patients, one thing that I didn't put in the slides, but it's something that we offer here at Prairie, is the CardioMEMS. So Dr. Nalamafu will insert the CardioMEMS, so it's a device that sits in the pulmonary artery. Some stipulations with this is they have to have class 3 symptoms, they have to be hospitalized in the past year. So he does a right heart cath, and we'll insert that into the pulmonary artery. So we check those on a daily basis, and that's like the earliest indicator that they're holding on to more fluid. And we can just diuretics based on that. So we insert them and then we try to find what is like every patient's different. So what is an acceptable PA diastolic reading for them? So they're all different in patients, and we try to find a good balance for them.
How's that communicated to you? Is it just like a pacemaker, or?
It's like they give them a pillow. It's a pillow they lay on, and they do the reading once a day, and all that information is transmitted back to us, and we can track that.
How does it transmit?
It's like a Wi-Fi.
Oh yeah,
But they have to have Wi-Fi.
What is that called?
Cardiomems. So
How long are these in for? Are they in forever?
yeah.
They can be indefinitely. Can they be removed?
I don't
Okay.
think they can. But I will say that the patients that we have that have the cardiomems, like, it's crazy because you can go from seeing these patients every couple weeks, every month, to not seeing them again for like a year. I mean, it's incredible. I feel like all of our diastolic patients should have this.
Because you're able to adjust meds based on the data that comes in
Yeah.
without them having to come in.
Yep.
And it's like way earlier
Oh,
than
way
their
early.
weight
Yeah.
would even
They
be.
might not even have a single heart failure symptom, and we start noticing that they're trending up. We call them, we adjust the diuretics a little bit, look to see if that number's coming back down, and then we just can just resume them back on what they were on before. I mean, sometimes it's obviously diet related, so if they've had they've had more salt in their diet, then we'll start seeing those numbers trend up. But they have to be somewhat compliant patients for this to work out, because if they're not, then it's just going to be chasing our tail.
Is it covered by insurance, Medicare, public aid?
I don't think Medicaid it's covered as well in Medicaid, but I think Medicare, that one too. So I mean, it can be. But
What are the guidelines for placing it?
so hospitalization within 1 year and class 3 symptoms. So I did want to touch on the sleep apnea. So any patient that you suspect has sleep apnea, and our office orders them quite a bit. I don't just say, I don't defer it to primary because it might not get done. You never know. So we can make the recommendation, but it might not get done. So what we've been doing is just ordering them ourselves. If we identify that they have sleep apnea, then we order CPAP, and then at that point we can have them kind of follow up with either primary or a pulmonologist if they have one.
We send anybody to Natalia, Dr. Reed's nurse practitioner. She specializes in sleep medicine.
Yeah. I think we've sent a few to her.
Because when she was here, she was like, just send them to me, I'll take care of everything.
Yeah.
So that might be even easier.
Yeah, I mean, you could do that too if your office doesn't.
We order a lot and then have Reedy read them and have Natalia see them.
Yeah.
And I've never had an issue. You get them with Natalia within a couple of weeks. You get them with Reedy in about 2 years.
Oh, yeah.
It's ridiculous.
Yeah, I mean, sleep apnea is huge. Patients that don't have treated sleep apnea are just going to feel horrible. I mean, you can be fighting heart failure symptoms forever in these patients. I mean, and then some of it actually might have all just been related to the sleep apnea. Mm-hmm. So if you suspect it, you really need to just be the one to initiate getting a sleep study scheduled and getting them on CPAP. So I just kind of added the recommendations based on the guidelines. So if a formal sleep assessment, if they have suspected sleep apnea, is a class 2A recommendation. 2B is the utilizing that CPAP, and a class 3. So this is actually harm in heart failure patients that have a reduced EF. That adaptive servo ventilation can cause harm in these patients. So if they have a reduced EF, you want to avoid that. So diabetes, this one gets me every time. So the drugs contraindicated in heart failure. So the thiazolidinediones, those are contraindicated because they can cause fluid retention and exacerbate heart failure symptoms in heart failure patients. Also, the preferred drugs for diabetes in patients with heart failure are the SGLT2 inhibitors. So this is your Jardiance, Invokana, Farxiga. What they do is they reduce glycemia by increasing the renal glucose excretion. Some additional benefits to these medications is that they have a diuretic effect, which can result in weight loss and reduction in blood pressure. This is kind of where it gets a little hairy because, you know, we're not the ones managing their diabetes, so it's a little difficult for us to initiate these drugs. But University of Chicago, they do initiate these medications quite a bit. So maybe it's something in the future we can work towards doing. All right, lastly is our stage D. So this is our refractory heart failure. These are the patients that have the marked heart failure symptoms at rest and the recurrent hospitalizations, you know, despite our guideline-directed medical therapy. Our goals of therapy with these patients are just to control their symptoms, improve their quality of life as much as we can. We want to reduce their hospital readmissions, and at this point we want to establish what their end-of-life goals are. There are several treatment options for refractory heart failure. The chronic inotropes we do here. We have several patients on chronic inotropes that we see, and they can improve quality of life, but it's more of a palliative measure. Any kind of heart, you know, if they qualify for heart transplant or the mechanical circulatory support, that would be, you know, like University of Chicago or West Jewish. There is experimental surgery or drugs. We typically don't do those here. Those, again, are done at UFC or farms.
So with University of Chicago coming here now, are we referring our patients who need all that stuff up to them now instead of up to St. Louis? So no, I mean, a lot of times we're referring to St. Louis because it was closer, but...
I would, because now they're coming here. So it's, you know, it's easier for our patients to be followed by University of Chicago because they're doing their clinics here.
And they're coming twice a month? Is that the plan?
Yeah.
Okay.
And I added a slide. I think it's the last slide. So I did add you know, something about our heart failure clinic. So at any stage in heart failure, you can refer to us. You know, we can start managing your heart failure. We offer same-day appointments. We have the IV Lasix in clinic. I did, you know, write our team here. But, you know, if they do have the advanced heart failure, we do now have UFC coming to Prairie 2 days per month. And they're, you know, if there's more of a need for them, they said they would come every week.
Oh, wow.
So we'll see how it goes. But if you have a patient that has advanced heart failure, so this is your difficult to manage heart failure patient, call Lasix, that's our extension, and we will start the referral process. So Donita and I are doing clinics with them, so we review anybody that, any patients that are being referred to University of Chicago, we will review their chart. We'd like to see them if possible, but there's some cases that we, you know, we review the chart and say, okay, yeah, let's just put them in clinic with University of Chicago. And
What are they doing different that Prairie wouldn't do?
well, so they offer the transplants and the LVADs. They do the experimental drugs or surgeries that we're not doing. So they also do more of like the genetic, which we do. We're starting to get into that more now. It's definitely underutilized. It's like the genetic cardiomyopathies, identifying amyloidosis or sarcoidosis. So those two, you know, I think we're going to try to start identifying those a little bit more. I think those are also...
a little more the inotropes bridging as well. We use inotropes more for...
We use inotropes for palliative care. Sometimes they'll use them for bridging, which we, you know, bridging for like a transplant, which we would not do here. But,
So we don't do transplants.
no,
Did in the past.
in the past, but yeah, I don't know that there is any...
for several years.
Yeah. So, you know, this is a good thing that we're offering, you know, at least for the Springfield area patients, you know, that they don't have to travel all the way up to Chicago to see these physicians. I mean, we did have a patient in clinic the last time they were here that did actually have to go up to Chicago to get some testing done that we didn't offer here. But all the other patients that we saw, they pretty much managed all of that here, and they'll see him back and follow up in a few weeks. So it's good. And so the amyloidosis and the sarcoidosis, so those are two, like I said, that there's a lot of different testing with those to identify, but the amyloidosis, so that's the protein buildup within the tissue in the heart, so the muscle. That's when you see like left ventricular hypertrophy.
Restrictive.
It's restrictive filling. You would want to do some more testing for that. And then the sarcoidosis that's granulomas. So the white blood cells are building up in the tissue, causing it to become thicker and more restrictive.
So, if we get an echo on somebody and they have LVH and restricted filling, should we send them to you guys to be evaluated for amyloidosis?
I think that's reasonable.
Okay.
And like I said, we're going to try to get into more of the
We
genetic
can start the genetic workup for sure.
workup too.
Because that's definitely not something I feel comfortable
Yeah.
managing, so I can.
And we've been provided with some of the genetic testing kits, so we are going to try to start utilizing that more in patients that are.
What's that
appropriate.
entail?
So it's actually just like a buccal swab.
Oh, okay.
Or saliva or blood test. So, we will try utilizing that a little bit more. It's just you have to find the appropriate patient for that. So, I think that's it.